This mini PowerPoint presentation lecture is going to be on peritonsillar and peritonsillar abscess. This is something that you're not going to see frequently at all in primary care, but I thought that you needed to at least be aware of the signs and symptoms and how you need to manage this patient. Peritonsillar is an inflammatory reaction of the parotid gland, and it can be caused by bacterial, by viral, by fungal, by mycobacterial invasion. But the parotid gland is most commonly affected by an inflammatory process, and the infections can usually range from acute or severe. They could be a local infection, an inflammatory process such as bacterial salivaritis, which is that's an infection of the salivary gland, or it could be systemic, which could be from the mumps virus, the paramyxovirus. And the paramyxovirus is usually seen more in children, obviously, in that age group, but it does happen sometimes in adults that they do get mumps. When you see a patient that has the acute viral inflammation, as I said, it's usually caused by mumps, and the acute suppurative is usually caused by Staph aureus. Somebody with mycobacterial, maybe the TB virus or HIV virus, could be infected with peritonsillar. This is a really good picture that shows you the parotid gland and the location of the parotid gland, which sits in front of the ear. You also see extending off of the parotid gland, the parotid duct, as well as the sublingual gland and the submandibular gland. So these are all glands that you would palpate when you're doing exams also. Acute suppurative is usually seen more on the right side than the left side. So if somebody comes in and you see that this is occurring on the left, you know it's probably the acute suppurative peritonsillar. It is seen more in the elderly patients where they may be taking medications that cause a decrease in blood flow. So that could be somebody who's taking an anticholinergic or an antihistamine. So it's important to get a medication history on these patients and see what they're taking to see if you can maybe figure out where their problem is coming from. Also, patients that have chronic illnesses, such as somebody with diabetes, with rheumatoid arthritis, somebody who's got renal failure, whether it's acute or it's chronic, or somebody who has some type of autoimmune disease. These patients will have a tendency to get this inflammatory process. Immunocompromised, we talked about a little bit, such as the HIV, and someone with poor oral hygiene, or someone who's had recent surgery. So this is a common post-op complication in somebody with abdominal surgery or hip surgery because they're dehydrated. And so it's maybe happens 1 to 2 weeks before or after surgery occurs, usually not any time after that. So it's one thing that you need to keep in the back of your mind if they've had surgery. There are some contributing factors that cause peritonsillar. One of them is the retrograde migration of the flora in the oral cavity, and it goes through the Stenson duct. There's also stasis of the saliva. There could be an obstruction of the duct, of that parotid duct, which I showed you on that picture. There could be decreased stimulation of saliva because of medications or even mastication, poor oral hygiene, and hypovolemia. Patients recent surgical patients, or even patients that are very ill, can develop stasis from acute or chronic hypovolemia. When you see these patients present to the office, they're usually not feeling really well. They have come in with a complaint that they've had a rapid onset of pain in the parotid gland region. It's very localized. They've got some swelling, some erythema. The area is indurated, and they're also not wanting to eat. They feel really crappy. They've got chills. They have fever. And it's usually only on one side. Remember, we talked about that. It's unilateral. So if you do see it bilaterally and it is not enlarged or painless, it's enlarged but not painless, then this could be an indication that the patient has HIV. So you want to be cognizant of the fact if this is occurring on both sides, you need to look further into this patient and see what's going on. On physical examination, it's important to determine if it's bacterial or if it's viral, and you can do this by palpating the Stenson gland. If you do get a suppurative discharge, then it is bacterial. If you do get a clear discharge with the edema, it is viral. And you can do labs on these patients. You can do a CBC to see if there's any leukocytosis or neutrophilia. Also, cultures and sensitivities should be performed, and fungal mycobacteria studies if indicated. So if the patient has HIV or the patient is a diabetic, you may want to do that. For diagnosing these patients with diagnostic studies, an X-ray of the soft tissue of the mouth and jaw can be done, and a contrast CT can be done, which would tell you, do they have a stone there or do they have suppurative parotitis? An ultrasound would be more cost effective in this to do this, but an MRI to see if there's any parenchymal changes. If you suspect there's parenchymal changes because of what you're seeing, or maybe you're identifying there's some atrophy there, then you might want to think about, could they have an abscess or could they have a neoplasm occurring? One of the things that I tell my students all the time is, and I even tell my patients this, if you tell me it hurts, I'm glad to see it hurts, because if you tell me it doesn't hurt, that makes me more suspicious that it could be some type of a lymphoma or some type of a neoplasm. So when your patient tells you that their gland is sore, you like to hear that they, not that we want to know that our patients are hurting, but we want to know that that might be something that is related to an infective process versus a neoplastic process. There are two options that you have in management of these patients. One is non-surgical and the other is a surgical intervention. If it's non-surgical, you can go with antibiotic therapy using augmentin, dicloxacillin, clindamycin, or even a cephalosporin in addition to metronidazole. The results will further direct your antimicrobial therapy and identify if it's MRSA, and then if it is, you may need to go on to vancomycin or even linezolide. Response to the antimicrobial therapy should be identified within 48 to 72 hours and should be continued for at least 1 week after they have had resolution of their symptoms. I also tell them to get either sweet tarts or sour candy or sour chewing gum or something to help to stimulate the saliva. Surgical intervention is going to be necessary if the drainage, to drain the infection if it is refractory for 4 days. And also if on CAT scan, then there is an abscess that's noted, then they are going to need to have surgical intervention. Because of the debilitated state of patients that are predisposed to parotitis, such as the diabetics and HIV patients and patients with rheumatoid and kidney failure and that type of thing, if they do have surgery and they do get parotitis, then the mortality rate is significantly high at 20%, So you need to just be keeping a very close watch on these patients. Now we'll go on to peritonsillar abscess. And a peritonsillar abscess is an accumulation of pus within the peritonsillar tissue, and it is between the tonsil and the pharyngeal constrictor muscle. And it is usually a deep infection of the head and neck, seen mainly in teens up until the age of about 40. It's not usually seen after that, but it can, it's just not common. For clinical presentation, these patients have a tendency to present very sick. They have a severe sore throat. They're having fevers and chills and fatigue. They have a very foul odor to their breath. They'll complain of otalgia as well as trismus. Trismus is the spasm of the masticator muscle. So when they're chewing or even in general, they get the pain. Drooling and hot potato voice. Hot potato voice is really a hoarse voice. But drooling and hot potato voice are the two that you really need to be concerned about with these patients. And this is a really good picture that you can see of a peritonsillar abscess and how you can see the left tonsil here and the right tonsil and that abscess right in between that area. Usually to diagnose these patients, it's done on physical findings. It really isn't done by any other means of testing, although you can do a CAT scan to confirm the abscess to see if it's there and if you need to refer to a surgeon. But the physical findings are usually done diagnostic enough. If you're going to do lab work, you want to do a CBC to look for any type of leukocytosis as well as neutrophilias, and monospot to rule out infectious mono, and a culture of the abscess would be something that you would want to think about doing. Serum electrolytes could be ordered if you think the patient is not taking in enough orally. As with any other suspected infectious process, they're going to run gram stain and cultures and sensitivity on any aspirated purulent material that you do send out to the lab. So how are we going to manage these patients? Well, with this patient population, antibiotic treatment is not sufficient at all. It's not going to work on these patients to do PO. They are going to require surgical intervention. They're going to need incision and drainage, possible tonsillectomy. They may need an aspiration, needle aspiration, and you will probably need to do adequate pain management and hydration. You'll probably be taking care of these patients in the hospital if you're making rounds or if you're doing the admissions yourself. IV antibiotics with a single high dose of IV steroids is really superior in these patients because it does help to take away a lot of the inflammatory process, and the steroids help with fever and they help with pain, the trismus, the dysphagia, the whole thing that goes with this peritonsillar abscess. This can be fatal if it ruptures, if the airway's obstructed, or if there's muscle necrosis. So you need to be thinking about your differentials with these patients. You need to be thinking about, do they have any type of possible epiglottitis occurring or a peritonsillar cellulitis? Could they have some type of a lymphoma if they're not having discomfort? Could they have a retropharyngeal abscess? So a lot of these things you're going to need to be thinking about when you're examining these patients.